I'm going to talk about a little broader view on digital health and where we might be going. My disclosures are here. So I'm going to talk about three themes. First is wearable technology and AI. The second is telehealth. And the third is the new last mile problems, which have been accelerated by COVID. So here's what we know with the market today. 81% of Americans have a smartphone. 96% have a cell phone. So the penetration is very high, and you can see the brand mix on the right of a different category. What is really impressive is what's going on with wearables. Right now, the market penetration is about 20%, mostly in Millenials. This is going up sharply, about 50% year over year. And the brand mix primarily is Apple and Samsung, with some of the others there. So this provides a large opportunity to really get data and deliver care in an asynchronous way directly to where patients are. We do an annual survey with Rock Health, which is a venture capital and health tech research company. We survey 8,000 Americans this last fall, right in the middle of the pandemic, to look and understand where people are with what they do. And so the majority of people in the US are seeking health information online, as you can see here in the gray bars on the right. But you can see everything else here as well. Telemedicine went way up, wearable ownership went way up, digital health tracking went way up as well. And so a lot is happening with COVID being a major catalyst for change. If you look at the timeline of wearable devices, they really started with technology from pacemakers in the early 90s that finally included digital signal processing. We've made our way through various devices, including a physician-prescribed smartwatch that could take an ECG. And actually, that watch you see has a fax port. You could actually have faxed the ECG directly to your doctor. But a lot has changed. We have the advent of AI, cloud, a renewed regulatory environment, and lower manufacturing costs. So we have the devices on the right, smartphone ECGs, watch-based blood pressure, and then irregular pulse and ECG. Now, this is the study that Mike and Roxana were referring to, which is the Apple Heart Study, and this was intended to validate an algorithm to use pulse checking to identify atrial fibrillation. And as you heard from Dr. Gibson, we were lucky in that we were able to enroll 420,000 in about 8 months. And we found that 0.5% of these people had an irregular pulse notification. So that's quite remarkable in terms of the potential new disease identified. And indeed, this did what it was supposed to with a positive predictive value of 0.84. So 84% of the time, when this notification went off, there was simultaneous AFib. That is actually higher than most insertable cardiac monitors, by the way. We now have point of care devices based on single lead, and this is actually a 6-lead device by AliveCore. So there's a lead on the back plate that's actually touching the knee there in that photo, allowing you to have 6 leads. For EP and arrhythmia management and even outpatient QT monitoring, this has some implications for drug loading, so it's pretty exciting. The other advance we have is Bluetooth. So a lot of the connected devices and implantables, such as loop recorders, pacers, and ICDs, have migrated to a Bluetooth low energy platform, allowing the patient's own smartphone to be the conduit for remote monitoring. And many of you have probably seen this in your practice. Now, let's talk about AI a little bit more briefly. First thing to note is the first time automated diagnosis and automated therapy were referenced in the medical literature that I have found was in 1962 in the top right in a book review. Marshall Brewster, all physicians who are paying taxes should read this book to become acquainted with the possibilities of automatic things, including diagnosis and therapy. If you like chess, Garry Kasparov was beaten over 20 years ago by Deep Blue, an AI machine created by IBM. We're very much in the same place with an analogous picture of radiologists have now been beaten by AI. This is a competition in Beijing in 2019. So it's not that AI is good, it's better. In chess, no grandmaster can beat AI anymore. It's used to identify cheaters, and we're getting to that point where we can use AI as the gold standard. There's been 4 accelerants with AI and machine learning, algorithms, infrastructure, processing, and you heard from Mike, a lot more health-related data. And this is really what's enabling us to do all this. And AI, I would say, is actually better than us already at many things. ECG, echoes, angiograms, a question mark, stress testing is a question mark. We're also getting good at predicting disease. So now, can you predict AFib from a sinus rhythm ECG? Can you identify low ejection fraction from an ECG? Not an echo, an ECG. And so there are some examples here. So here's a neural network model that showed that a neural network that we created, this was some work at Stanford and Andrew Ng's lab that we all worked on using 64,000 Zeo patch strips, had high agreement with the gold standard. So this was 9 consensus cardiologists and EPs. When we then road tested this to a separate population of cardiologists, it actually outperformed the average cardiologist. The other interesting thing is that the classifications recapitulated human error. So occasionally AFib would get mixed up with atrial flutter or atrial tachycardia. Wenckebach would get misclassified as other forms of heart block. The AI made the same mistakes that humans do, and when that happens, it's much more predictable. This is an example by the Mayo Group of using an ECG to identify left ventricular systolic dysfunction, which actually works quite well. Now, who even cares about the ejection fraction at some level if you can go straight to the disease to identify it? And so a variety of deep learning algorithms have shown high discrimination for detecting things like HCM, amyloid, and pulmonary arterial hypertension. So forget about the surrogate measures of ejection fraction or wall thickness and go straight to the disease. This is also being done for quantitative coronary angiography. Many groups are working on this, and I think it has promise, but as an EP, I don't know this data as well. We're also seeing N of 1 training. So the idea that you train your own AI, and Samsung has a watch that's been not approved in the US where it will use the pulse contour to look at and train against the blood pressure cuff on your measurements at home, and then it will then make inferences to be able to estimate your blood pressure simply from the pulse contour on the watch. What about vocal computing? So how many times are you in the lab and you start asking for things? What's the EF? Go to LAO 30, turn on RF in the case of the EP lab, and do all these other things. And so can we have vocal computing assistance in the cath lab in a safe way? I think the answer is yes. A few companies are working on this. This stuff is not perfect. You've seen this cartoon, and the first problem is engagement. You can't list your iPhone as your primary care physician. And we are seeing this in the next generation of what I call our patient base, the millennial population. Turns out, based on claims data, they're less healthy than Generation X if you match them for age in terms of the prevalence of conditions. The 4 circled are actually much higher in millennials compared to age-matched Gen Xers. Yeah, we think it's a healthier generation. The data suggests otherwise. And the other notable thing I should say is that only 2/3 have a primary care provider, so that presents an issue as well in this population. And what we're now seeing in this population, irrespective of COVID, is on-demand convenience. And so millennials are not looking for Michelin-starred doctors. They're looking for DoorDash doctors. They want what's convenient. They want to go where it is. And so this is the opportunity for all of us at our healthcare systems, is how do we improve that user experience? Because if we're not going to do it, it's going to be these companies that you recognize from other things that are on the screen. Patient satisfaction is quite high for telehealth. This is our survey from 8,000 Americans. If you pay attention to the dark green and the light green, people are generally satisfied. And I think that bodes well for our future, especially for a lot of things where you can bring the diagnostics at home. At Stanford, we've rolled out virtual second opinions. This is a separate service we have where you actually get all the data in a separate portal and you provide your recommendations. Again, that's another way of thinking of DoorDash care delivery. The second one is disease management. We haven't really figured out if virtual visits are delaying care, and what do you do for complex diagnosis? So this is a proof of concept of the fact that you could actually get a 12 lead from an Apple Watch. And this is not the way to do a 12 lead, but it makes the case that we need these complex diagnostics at home. Here's another thing that you can buy at a retail outlet. Most of this is geared for pediatrics, a tongue depressor, and an otoscope, but there is a stethoscope here. And so this is to do a home-based exam by the patient or by a caregiver directly to themselves with you watching over a video camera. Remote echo is also coming, and so Butterfly has I have this device. It's a beautiful device that can work and allow you to take echoes. If you have someone who's holding the probe and they're less experienced, there's actually a FaceTime app where you can walk them through doing this. Now, can patients and caregivers do this? That's a challenge, but untrained clinicians may be able to do this quite effectively. And so we're getting to the point where we sort of have an app store for all the things we consume on media, but we're getting to that place where within Epic or your EHR, you may be pushing buttons on prescribing things. We've done this and are rolling this out for hypertension to guide semi-automated asynchronous management so that patients don't have to go back and forth, and medication titration can be done in an automated way. We'll then move on to heart failure as well. Now, a lot of companies are in this space, but it may be a bridge too far. So we have a lot of technologies where you can actually identify AFib just from a video camera from facial plethysmography. But somebody has decided to make a toilet with sensors as well. I don't think we're going to be going to Home Depot to pick this up anytime soon. And so there will be some limits, but the smart home is going to be here to stay, and there will be sensors based on at home. So I'll close to say that digital health, in my view, is basically health. It's becoming a more redundant term, and some of the technologies are here to stay. There's a lot of challenges, including engagement, virtual delivery, and evidence generation. But remember that the millennials represent our new wave of patients, and they're going to take their healthcare a la carte and asynchronous, at least the outpatient care. And I do think that as a clinician, the next 20 years will be quite different than the last. Thank you.
Mintu, unbelievable. Thank you for that wonderful lecture. And both of us want to have just a short question for the next minute. So what's the role of the doctor then, 20 years from now?
Well, a cell phone can't put in a stent, at least not yet, right? I think it's very much the analog to what you talked about, or do AROs have a future? I mean, there is the social, intellectual, and other capital you need. You need doctors coordinating this stuff. We aren't at the point where AI can make complex decisions. Patients need to talk to doctors. They are there. I think what happens is the more mundane stuff starts getting automated. Okay, the frequent callbacks to titrate heart failure medicines, the frequent callbacks to optimize hypertension, the loss to follow-ups ideally start getting mitigated. And so we're definitely needed, and we're needed for more than procedures, which we all love doing. So again, I think this augments us. It doesn't replace us.
Thank you.
AI is a bit of a black box, and now AI is being used to design chips. So now we have something that is a black box that you don't know why it's designing it the way it's designing it. Are there dangers to AI?
Yeah, so it's true. So AI really doesn't care of how the solution is learned or how it's arrived, right? And so, you can have, there is AI. Michael, you're a gifted painter and artist, and AI can get you to something that to some people may look aesthetically pleasing. You've lost the entire process and the journey of designing that art. And I very much think that is a great analog to what we're seeing. The importance is that there is a new kind of emergence of what's called explainable AI, right? And demonstrating what they call feature importance. So if you look at the ECG AIs, the journals are also now requiring this. The FDA is looking for explainability assessments to really get under the hood to better understand. Sometimes you want to see that it recapitulates the way we think about it. Other times you may have new discoveries because it identified patterns that us mere mortals could not.
Well, my favorite example was AI predicting whether a melanoma was going to be fatal.
Yeah.
And it all just turned out to be the fact that there was a ruler on the image, and anyone who had a ruler on the image had a bigger lesion and was more likely to die. That was the explanation.
Yeah, and that's why you need to validate in external data sets that don't use rulers.
Well, this has been a fantastic session. We want you all to go now and take a break.